Hello, everybody. Hi, my name is Dr. Rishi Gogineni with OrthoVirginia, and welcome to our Facebook Live event. So for those that might not know OrthoVirginia, we are the largest multi-specialty orthopedic practice in Virginia. We have offices in Northern Virginia, which is where I practice, as well as in Richmond, Lynchburg, Southern Virginia, and Virginia Beach as well. If you'd like to get more information about OrthoVirginia, please go to our website, orthovirginia.com. So a little bit about me. I went to medical school at Case Western in Cleveland, followed by an orthopedic surgery residency at The Ohio State University. I then did subspecialty training at the University of Florida, specifically in hip and knee arthritis and in hip and knee replacements as well. I started my first practice in California and practiced there for a few years before finally moving back home to Virginia to be closer to my family. I have two small kids and we are expecting two more in a few months. We also have an old dog who is not happy about all of these kids. All right, enough about me. So let's talk about you. So topic today is when to consider surgery for hip and knee arthritis. So I know you have a lot of questions, so let's keep it short and we'll have more time for questions. So I'll begin by talking about what arthritis is. So what is arthritis? Well, arthritis is degeneration of a joint in the body. And you say, what is degeneration? Well, degeneration of a joint is what we say when there's damage to multiple anatomic structures in a joint. So a joint is made up of several structures, including the bones, cartilage, meniscus, labrum, the capsule, tendons, ligaments. So when there's damage to several of these structures at the same time, we call it arthritis, which is the umbrella term for all the damage. How does it present? When several of these structures start to show damage, the joint just doesn't start to move the way it used to before, So it starts to have pain and weakness, rubbing and grinding and stiffness and limp. And, it also puts patients in a bad mood, causes depression as well. And that's how it typically presents. So then one might say, what caused these structures to get damaged in the first place? There are lots of reasons, but the most common one tends to be wear and tear on a joint. Just usage of the joint over a long period of time. Other causes can include things like autoimmune conditions where your body's attacking your own joints, which is what rheumatoid arthritis is. It can be post-traumatic, which is what can result from a history of trauma to the joint, like fractures. It can be genetic and run in families, or it can be a combination of all of these. What should a patient do when they start to notice symptoms like that? They should see a doctor. You can start with your primary care doctor who can start the evaluation process, maybe even start some basic treatments or eventually refer you to someone like me. Or if your insurance allows, you're welcome to come see us directly and we can take care of you with this problem and be with you from the journey from the start. So what does this evaluation consist of? Well, typically it would consist of first a good history. So, getting good information from the patient about their symptoms, when they started, how they started, what works for them, what doesn't, what activities are the most uncomfortable, followed by a good physical exam of the patient and of the specific body part. We almost always will get x-rays, and sometimes we'll even get some advanced imaging like an MRI or a CT scan if needed. What treatments can we offer? If we determine that your diagnosis is indeed arthritis, we will almost always try to treat first with conservative treatments. We will typically try to do oral anti-inflammatory medications, physical therapy, ice treatments, heat, and braces, and we can even do injections if needed. And some patients tend to ask, if those treatments work for patients. And I'll tell you that they do work for many patients. They are able to either delay or even put off surgery indefinitely. And these patients become quite functional. But I will tell you that for some patients, they don't work. They either are not able to give them the relief they're looking for, or they might only give them a small amount of relief. So, and a lot of those patients for whom they don't work as well might be patients that have more advanced forms of arthritis. Also, we do sometimes see patients who are finally only coming in to see us after a long time after their arthritis is already quite advanced. So for those patients, conservative treatments are not appropriate. This is a roundabout way to get to the title of our talk, which is when to consider surgery for hip and knee arthritis. And the answer to that is when patients already have quite advanced arthritis, or if they've already exhausted all the conservative treatments that we can offer and still don't have the relief they're looking for, that's when they should be considering surgery. This is, of course, a decision that we can make together because, as you can see, there are a lot of caveats to this process. So with that, I'd like to address any questions that might be on your mind. Please ask them in the comments below.
Thank you so much. So a question that came in before we started, somebody is concerned about the activities that they are doing now, and they want to make sure that they're able to continue doing them after they get a joint replacement. So they're specifically asking about skiing and how long a knee would last if you play tennis and walk on the golf course.
So excellent questions. I'll give you a brief answer because we'd like to address some post-operative or recovery questions as well in another talk. But I'll tell you that most patients are able to get back to their prior level of activity after joint replacements. So we'll tell you that non-impact activities are completely fine for joint replacement. So walking on a golf course, no problem with doing that. Some patients are even able to ski after joint replacements. But impact activities or repetitive impact activities like running or running a marathon or long distance running is something that we don't advise. And we're not sure what that actually does to a joint, but we think that it may cause early loosening of joints, the repetitive impact activities. But non-impact activities like cycling, completely fine. I mean, you can cycle as long as far as you want, and that shouldn't really affect a joint.
Thank you. When you're diagnosing arthritis, I'm guessing that you take x-ray. Do you also do CT scans or MRIs to diagnose it?
Only if needed. So most of the time, those of us experienced with arthritis are quite comfortable making the diagnosis on just x-rays. In some patients, if it's not clear enough on x-rays, or if we feel like there's something else that we might be looking for, in those patients, we will do advanced imaging as well, like MRI or CT scans.
Thank you. Can you be too young for a joint replacement?
No, you do not have to. We don't go just off of the age. That was something that we used to do in the past with the concern that a joint only lasts a certain amount of time, so we wanted patients to be older before getting a joint replacement. But our thinking is changing on that. If a patient is young but has severe arthritis or advanced arthritis, as I mentioned earlier, and has exhausted all other treatments, they don't really have much more of a choice. So for those patients, we don't want to leave them non-functional. So we will still do a joint replacement on those patients, just with a good discussion that it is possible that they may need revision surgery in the future. And you know what, we'll cross that bridge when we get there too.
Thank you. A couple of related questions from separate people. One person was asking how physical therapy helps arthritis, and someone else asked if physical therapy is available as an option for long-term maintenance care to help put off the need for a joint replacement.
Great questions. In fact, it's a question I commonly get from patients because they say, oh, if my joint structurally is damaged, how would physical therapy be able to change that? So tell you that physical therapy is very good at improving the range of motion of a joint when they start to get stiffness in a joint. So when people get arthritis, they start to get stiffness, they start to get weakness, they start to get loss of their strength as well and coordination. So physical therapy is great at restoring some of those things. Will it completely eliminate pain in an arthritic joint? Maybe, maybe not. In some patients it can, in some patients it might not be able to, but in almost everybody it does improve their range of motion. and functional level as well. Your second question, I think, was about maintenance or to keep arthritis at bay. And yes, that is also helpful for a lot of patients. You don't have to keep doing formal physical therapy with a physical therapist for a long period. You can learn a lot of the exercises and then do them on your own afterwards. And I think that's also very useful for patients.
Thank you. Do steroids help with arthritis?
Yes, they do. In fact, that's one of the mainstays of conservative treatment that we offer for patients. So steroids are a strong anti-inflammatory medication. So we can use them to decrease inflammation that is going on in joints, to decrease the pain in the joint. That allows patients to be much more functional and might even be able to help them or allow them to do physical therapy more effectively since they'll be in less pain.
Thank you. Someone is wondering if painful bursitis flare-ups are an indicator of future arthritis in a joint.
Not necessarily, no. Bursitis is a different condition and is caused by different issues than arthritis is. And bursitis can really happen at any age. Younger patients can get bursitis as well. Older patients can get it too. Not necessarily associated with arthritis. You can sometimes have them both at the same time, but it's not that one causes the other or that one is indicative of you getting the other.
If I have arthritis in both my knee and my hip, which one do I treat first?
So the way that we typically treat patients who have both hip and knee arthritis is we first try to find out which one is more advanced or worse in the patient, which one has affected the patient for a longer period of time, and usually we'll try to address that. But more often we do like to work, if possible, we do like to work from a top-down approach, and we try to address hip arthritis before we address knee arthritis. But if someone has really bad knee arthritis and have milder hip arthritis, we will usually address the knee arthritis first, and then reevaluate and see if they still are in need for any hip replacement surgery, or if they're quite functional and are doing very well with minimal pain and may not even need a hip replacement after. So, well, the short answer is we'll try to address the one that's worse for the patient.
Thank you. Does the type of arthritis matter? For example, arthritis caused by Lyme disease compared with just arthritis from regular aging?
When it comes to conservative treatment, we can try to treat all of these different arthritis conditions with the conservative treatments that I mentioned earlier. And if they don't work, we can consider surgery. So the surgery for most of these would still be the same. We would still do a standard joint replacement, whether it was from rheumatoid arthritis or from Lyme disease or osteoarthritis. So the surgery is still quite similar. Recovery is similar as well in patients.
Thank you. We have several questions about cortisone shots and other injections. So people are asking who can get them, how long they last, and how many they can get.
Almost everybody can be a candidate for getting cortisone injections. In patients who are diabetic, cortisone injections can slightly increase their blood sugars for a few days. It doesn't mean that they can't get those injections. It just means that they would need to watch their glucose levels a bit more closely for a few days after such an injection. And I do them in diabetic patients as well. And so almost anybody can get cortisone injections. The gel injections are a different type of injection, which is a different material that is injected into a joint. We think that it helps patients more in their earlier or moderate stages of arthritis and is not as helpful in the later stages of arthritis. The second barrier with that gel injection is it's also quite expensive, so it's also a little bit harder to get insurance approval to be able to do that injection. But we do that in patients as well. How long do these last? It's variable for patients. In very advanced arthritis, it may not even last a few weeks, and those are the patients that know that they might be ready for surgery. But in some patients, I've had patients in whom it has lasted easily for a year, sometimes even a little more than a year before they come back asking for another injection. So it's a big spectrum. It can be anywhere in between.
Thank you. This may be good for this week. It may be good for another time, but somebody is asking if a hip replacement will help with arthritis in the lower back. Are those related?
Yes, they are. So hip arthritis and lower back arthritis tend to be something we do find together in a lot of patients. Does not have to be, but we can find it together in a lot of patients. And sometimes we also have a little bit of a harder time teasing out what the cause of their discomfort or pain is. Is it coming from their lower back, or is it coming from their hip, or both? And if it is truly coming from their hip joint, we can of course go through our algorithm of treating patients with conservative treatments, and if that's not helpful, then we can also consider surgery for those patients, and we do. After hip replacement, a lot of patients do tend to feel, assuming that they've got spine arthritis and hip arthritis, and both are just as bad, a hip replacement does make patients feel better, may not fully resolve all of their back pain, but does tend to make them feel better with their back as well.
Thank you. What if you have arthritis in both of your knees and are having trouble walking? Can you treat both of them at the same time, or do you need to do one at a time?
Yeah, great question. It is possible to do them both at the same time. Doing them both at the same time in the same surgery is doable. Many surgeons do it. I'll tell you personally, I prefer not to do them at the same time, and my reasoning is as follows. So, if you did them both at the same time, recovery, I think, is much harder. If both knees are painful for a patient, it makes it much harder. If both knees are painful from surgery for a patient, it makes it much harder for patients to find the motivation to get up and get out of bed and start working with physical therapy. And physical therapy is very important after knee replacement to really get that range of motion back again. For patients that don't do the physical therapy or are slacking with their physical therapy, those are the patients that don't end up getting a great outcome with their replacement because they get stiffness and weakness in their knee joint. So in order to allow patients to be able to work well with physical therapy without causing them an excessive amount of discomfort from surgery, I prefer to do them one at a time.
Thank you. What is the time period between having a cortisone injection and having a replacement, or between having the gel injection and having a replacement?
So most of us typically will quote 3 months as a minimum amount of time when you get any type of an injection before considering surgery. So why is that? Well, there's been some data that has shown that the risk of an infection in a replaced joint there is a risk of infection in a replaced joint if injections have been done within 3 months prior to the surgery. So I always ask patients to at least wait 3 months after an injection.
Thank you. Does conservative treatment for arthritis have any dangers for an elderly person? What about replacements?
Yeah. So for most patients, conservative treatments do not have any bad negative side effects that we need to be strongly concerned about. Having said that, all medicines have some side effects, right? So even things like Tylenol and ibuprofen and Advil can have small side effects that if we're not careful about those medicines, they also can have side effects. So with some care, we can still do conservative treatments even in elderly patients. Now, regarding replacement, that's fine too, but we should handle that, of course, on a case-by-case basis. For me, personally in my practice, the oldest person that I've done a hip replacement in is 96 years old, and a knee replacement is 94 years old. So in those patients, case by case, we evaluate all of their health. I have them go meet with their primary care doctor, and if they have any other conditions like any pre-existing heart trouble, I have them meet with their cardiologist as well. If they get okays from their other doctors, then with good counseling, we'll go ahead and proceed with doing the replacement. And with good anesthesiologists, we're able to do these replacements softly, or not softly, carefully with gentle anesthesia as well. So age is not a barrier. We just want to make sure that the health conditions that they have are not things that we can't handle.
Thank you. When do I know it's time to come see an orthopedic surgeon instead of my primary care provider?
Usually your primary care provider will usually give you a referral to come see us after they feel that they've exhausted what they can offer for you. That would probably be the most straightforward way. But if you, for your peace of mind, if you wanted to come see us earlier, that's fine too. You know, we don't operate on everybody that comes through our doors. Some patients just need some reassurance, and we're happy to provide that as well. So we are happy to see you at any stage of your journey.
Thank you. If physical therapy exercises are not working well, is that time to start thinking about a replacement instead?
It might be, but you know, there's a lot more things that will go into that decision as well. So I would say, you know, always have that discussion with if it's with me, with myself, or with your orthopedic surgeon about the timing for when, because there might be other things that might be going on, and it might not be replacement. It might not be time for replacement. Maybe something else might need to be evaluated. But in general, if conservative treatments like physical therapy are not helping, as well as anti-inflammatory medications and injections and activity modifications, if these things are not helping, it may be time to consider surgery.
Thank you. Is there any sort of metric for how somebody chooses who their orthopedic surgeon is? What should they be looking for in their surgeon? Should they have been trained in a specific technique or in a specific time period?
Yeah, so a joint replacement is something that a lot of surgeons are able to do, but there's a subspecialization within orthopedic surgery, which is what we call hip and knee replacement surgeons, or the fancier word is arthroplasty surgeons. Arthroplasty means joint replacement. So hip and knee arthroplasty surgeons have additional subspecialty training specifically in hip and knee replacements, and the revisions that come with it, and the complications and complex cases. So myself and others in my subspecialty do that line of work. So I think it would be better to get a joint replacement from a subspecialty trained surgeon. Having said that, there are a lot of surgeons who have done this for a long time, way before this subspecialty was something that was that became popular. So even an orthopedic surgeon with a vast amount of experience who may not be subspecialty trained would also be a good surgeon to be able to do this surgery for patients.
Thank you. Do you suggest wearing a knee brace or using mobility aids like a cane ahead of surgery to put it off longer?
No, I'm completely okay with what we call gait aids, which is walkers, canes, and such. So gait aids are fine to use. They are not bad for your joint. If that's all that your patient needs to be more functional and be able to do the things they want to do, by all means, you don't necessarily need a surgery. If you all just need a cane, then that's completely fine. I'm not against using gait aids at all.
Thank you. You mentioned anti-inflammatory medications. Are these just the regular ones that people can take over the counter? Just the dosage is listed on the medication, or do they need to see a doctor before taking them?
I would advise patients to try over-the-counter medications first and follow the dosing on the medication. There are some prescription level medications in the same category, in the anti-inflammatory category that we physicians can provide, primary care doctors or myself that we can provide. But I would advise that you try over the counter first.
Thank you. Somebody asks, when their injection is starting to wear off, should they go ahead and schedule another one before the pain and stiffness get bad?
No, it's okay to wait, because that way you'll get a good idea of how long it is lasting for you, so that you can have that discussion with your orthopedic doctor or myself about when would be a good time to get an injection, or should we now be considering a different treatment or surgery. So it is okay to wait even after the injection has worn off if you can tolerate the symptoms.
All right, thank you so much. If we did not get a chance to answer your question live, we will answer it soon in the comment. Would you like to close?
Sure. So I wanted to say, well, thank you everybody. Thanks for everyone for taking the time to attend this talk. I really appreciate it. I certainly enjoyed this format. I'd like to do more of these going forward. If you think this information would be useful to a friend or a family member, please do share it. You can use the share button. If there are any other topics you'd like to hear about, please let us know by putting them in the comments, or let me know in person when you come and see me in the office. You can find me at our Stone Springs office, and in a few months, we're going to open up a new Ashburn office as well, and you'll be able to find me there too. Thank you, everybody.